Thank you very much. It's a pleasure to be here. Well, one thing you can tell from the title is that I really, really like acronyms. I'm sort of the designated acronym maker in our group. I have no disclosures that are relevant for this. Let me just start by saying that the research that I'm going to describe, the first part, I'm going to describe sort of two projects, a part of one project and a bit of a part of a second project. And these sort of started in the aftermath of the controversy over the support trial and in my view, as I published this is in a secret, deeply misguided overreach by the Office of Human Research Protection in their criticisms of support. There was a lot of talk at the time that happened about what patients think about this kind of research on medical practices, research involving randomization among usual practices, however, is comparative effectiveness research, point of care randomization, pragmatic trials, learning health system, all these different terms for pointing in some of the same directions. But we really didn't know what people actually thought about it. Nobody really studied that. And so we and some other groups were given some funding to really look at that, to really address the empirical question about what do the public, what do patients think about research, the ethical implications of randomization within usual clinical practices, which we call ROMP, research on medical practices, and how should these attitudes influence policy and about approaches to informed consent. And the results I'm about to present are not just mine, the result of a very large research team of investigators, primarily based at Stanford and Seattle Children's Hospital, as I said, with funding from NCATS and the Greenwald Foundation. And we've already published quite a bit in the last couple of years since we started doing this research. We've published a total of about 10 articles, including all these different empirical pieces that we've published from the data that we've been collecting. Again, we're talking about ROMP, that is research comparing medications or treatments that patients are already getting, as opposed to RENT, or research to evaluate new treatments. And again, we know there's lots of different options that people often don't know what's best, and this is research trying to answer those questions about figuring out what those best things are. You'll notice you've seen some of these comic images. As part of our research here, we developed a set of comics and illustrated videos to explain some of the key concepts, and then those videos have in turn been used by some of the other teams that have also been doing similar kinds of research at Penn and Duke and Hopkins. Our overall ROMP study included focus groups and surveys. We partnered with Primer and we surveyed 1,500 randomly selected Primer members, and we got a 40% response rate of over 500 Primer members we had 600 total respondents, over 500 of them were IRB members or professionals of one sort for IRBs who are included in our data analysis. We also did a nationally represented sample of the public that we did a survey of, as well as patients from specialty clinics in Spokane, Washington. The data I'm about to present is really data that compares this IRB data along with our patients' Spokane data. Although, in fact, our findings in the Spokane data was very similar to the findings we found in the nationally represented panel data. And basically we did surveys, two separate surveys of the IRB members, and one of we did the same survey of both the general public and the patients. We used the videos that we made interspersed to educate people, gave them different scenarios, and it was a mix of sort of scenario-based questions and general questions that we did. And for the IRB group, we had those scenarios without the videos and general questions. And because we weren't sure whether that would make a difference, we randomized, half getting the scenarios first and then the general questions, and half the other way around, and it made no difference in terms of the outcome. We published the results of this comparison in clinical trials recently, and here's some of the differences that we found that are interesting and important. First of all, and just let's see, is there so this is a preference for documented written informed consent, verbal consent, broad notification, and no consent at all. And what you can really see very graphically illustrated here is that IRBs see a huge difference, as indeed does the regulatory system, between randomization versus observational medical record review. They see those things as really fundamentally different. And patients don't. Both in our public survey and our patient data, they really did not see a very big difference between those two. And while they want informed consent of one for another, they're a little bit more willing to have verbal discussion. There was just generally but they were not nearly as, but they saw these things as pretty much the same and not much difference compared to IRBs. In terms of what was the minimally acceptable approach that you had to have in order for the research to be able to go forward, again, IRB professionals see randomization as requiring at least verbal or written permission always, whereas we actually found when we looked at the public, given the trade-off between the value of research and the consent requirements, they were willing to accept broad or no notification as acceptable most of the time. And in fact, this was even more pronounced than in the group of the public. They were willing to lower the consent standards to broad notification as long as the research go forward. So again, a huge discrepancy between the way IRBs look at things and the way patients look at things. About the question of who can obtain consent, we found also similar differences. These are of the IRB members, and you can see about half thought it was okay to get consent from anybody, either the clinician or a researcher or a study coordinator. But a significant number of IRB members think that you should never get consent from, or that it would be ethically problematic to get consent from a patient's clinician, and then a small number thought you should only get it from a patient's clinicians. And this led, again, to significant differences between the way IRBs look at this, where in this number you can see 65% thought either a researcher or a study coordinator could give consent, and only 35% would be or should be getting consent from clinicians. In contrast, for patients, it was exactly the other way around. What we saw in our focus groups, what we saw in this data, patients want their doctors to be the ones telling them about it, while IRBs are nervous about having doctors playing that kind of role. There's some limitations to this part of the study since the two surveys were not worded necessarily identically because we weren't necessarily intending to do a comparison, so it was a post hoc analysis. And of course, the Spokane data, unlike our population survey, which was representative, were largely old, white, lower income healthcare users, unlike our general population. But our general population had very similar findings as well. So what are some of the key differences between IRBs and patients? IRBs distinguish between medical record review and randomization, while patients' consent preferences are much more consistent. Patients are willing to accept less elaborate consent approaches, broad notification, or even no consent, even when IRBs identify traditional written consent as the minimal acceptable approach. And patients prefer consent conversations with their doctors, but IRBs are split on whether this is ethically appropriate. Now, and for people who want more information or want to get access, anybody can use these. Our videos, our comics, all of our instruments are all available online, and anybody can get access to them. We've got them all available through YouTube, so anybody can see these 3 videos that we've developed. I want to talk a little bit about ROMP 2, which is talking more about electronic health records research, building on that, and also talking about biobanking. And again, most of the same researchers at Stanford and Seattle Children's, though we've added folks from Sutter Health and the Palo Alto Medical Foundation to this project. Again, we engage in a similar kind of activity of creating videos, and so these are not yet publicly available, but soon will be. We've created 6 new, again, short 3-minute videos, illustrated videos to explain these things, and we've got them in English, Spanish, and Mandarin. And we wanted to try and create materials that were appropriate for cultural context and health literacy of different patients to talk about biobanking and medical record use of medical record research. And we spent a lot of time actually developing the right images, the right metaphors, and the right language for those sorts of things. We don't talk about biobanks because that had different kinds of associations with it. Instead, we call it the Library of Medical Information. So instead of the learning health system, this is the metaphor that we found to be most useful and seem to resonate with most populations. There's lots of others who have studied biobanking. Jeff Bakken, who spoke earlier, has done a lot of empirical work in a lot of populations, but we were including some populations that have not really been very, very well studied so far. And then this is a mixed method study where we've done these video developments with multilingual trigger films. We've already conducted focus groups, which I'll talk about in just a second. And then what we're about to do is an actual pragmatic randomized trial as Sutter is recruiting for their biobank Coming out of our findings, as well as the work of Jeff and others, we actually think, and Rich had talked about this a little bit, that the oversight and governance approach matters to a lot of these people. So we've come up with an approach to governance that they've adopted and an intervention to explain that governance. And so and they're doing the recruiting, they're being randomized to getting in the recruitment information about the governance structure. And we're going to see whether it actually has an impact on recruitment, and especially recruitment for underrepresented groups. And we're also going to be doing follow-up surveys of those people to see whether or not it impacts their trust in the system. So we've done focus groups and analyses, 20 focus groups of their patients, including 4 groups of African-American patients, 4 groups of Chinese patients, 2 of which had people who spoke English, 2 that were conducted in Mandarin, 2 in English and 2 in Spanish for the Hispanic population, 4 non-Hispanic white groups, and 4 groups representing South Asian populations conducted in English, a total of 122 participants. Codes were developed. We had a good inter-rater reliability in our analysis, and then we did a team-based thematic analysis. There are 4 themes that came out of this that were, I think, really interesting that came out of our data, and that resonate with a lot of what's already been talked about today. First of all, the framework, in a way, it's very different. Our regulatory system is really framed on issues about autonomy and risk. And that's really one thing we heard in all of the ROMP 1, ROMP 2, everything we've heard is that's just not how patients look at things. They don't look at things primarily in terms of either risk or in terms of autonomy. They tend to think of it in terms of issues of trust and trustworthiness. And so that became a really major overarching theme, is that their support of the Library of Medical Information is conditional on institutional trust. Yeah, they're concerned about appropriate access and use of the library and resigned to worries about data breaches. They do view consent as important for demonstrating respect, but like our studies in ROMP 1, they recognize its trade-offs and limitations, and most people were willing to say if the consent requirements got too burdensome and made it too hard to do the research, they mostly wanted the research to go forward, as long as it was done in the right way, in a way that was trustworthy. And their trust in the library depended on the existence of oversight and governance mechanisms that met their expectations. I'm only going to focus on that first set of theme about institutional trust. All groups expressed general willingness to participate in the library and said they believed research would benefit future patients or individuals like themselves, and recognized limited applicability of current research findings because of the historic enrollment of white males in clinical studies, and expressed the view that different racial and ethnic groups have different health problems, and use of racial and ethnic identifiers in research could help address those problems. But their willingness to participate was conditional on trust in physicians, researchers, healthcare systems, government, and corporate institutions. And while lack of trust was expressed in all groups, historical discrimination and abuse was especially brought up in the African American groups, while other groups, especially the Hispanic, Chinese, and South Asian groups, suggested there's a general lack of engagement by recent immigrants because they are unfamiliar with the healthcare system and research, and that this is an underappreciated problem that they think needs to be addressed as well. And patients were more willing to participate if there were assurances of transparency and that patient concerns would be addressed. So where do we go from here in all of this? One of the primary roles of informed consent is to demonstrate respect for persons. Our findings reveal discrepancies between the way that our regulatory system and our regulators view these issues and the way in which the public and the different publics view these issues. Policy deliberation among IRBs, research, and the public can help develop an approach that both respects participants and achieves research goals to improve healthcare. And I want to end with a wonderful quote from John Lantos in an editorial he wrote that accompanied our first empirical piece that we published in Annals of Internal Medicine. It is time to ask whether a system in which the fundamental principle is respect for persons can continue to ignore the preferences of many of the persons it claims to respect. Thank you very much.